We are looking at specifically within New York State, having pharmacists and healthcare providers have access to a prescription data warehouse, where if you come to me and I'm a pharmacist, I'm filling your prescription, I can actually query a drug database that's national. So you'll say, well, how many other prescriptions have you had filled for this drug in the last 30, 60, 90 days? So there are a couple caveats there. If you're paying cash for a prescription, it may or may not be in there. Okay, but so those are some things that we are doing. In order to reformulate a drug, you're probably looking at minimum 7 years before it's going to be available on the market, because of all the testing that is necessary to actually reformulate a drug. So I'm sure that there are things right now where they're looking at trying to reformulate drugs and using drug combinations so that you'll stunt some of the euphoria that you see and decrease the abuse of it. So we are looking at a lot of those different things in combination. We're looking at increasing the level of control for some narcotics. So the highest level of control is a substance, a category 2 substance, class 2 substance. There are more regulations around a class 2 than there is for 3, 4, or 5. So they're looking at moving some of those narcotics that are technically a class 3 controlled substance up into a category 2, so that it will limit the number of day supply that can be given and the amount that will actually be available on the market. So whether or not that's going to work, I'm not sure.
On a second question, when you put up the 1 million scripts being voted for it, that, take up 13% and possibly 13% of the population, is the multiple factor, defining the user, doing it and abusing it. It must have a quantity or an average quantity that I am taking. That, is it all coming from the legal scripts that are going through the process through the pharmacy, or is there, like you said, you shut down Florida and Kentucky, but is there other, numbers coming up? Because it just seems, and even here for Staten Island, we talk about pharmacies. I know 2 pharmacies ripped off or held up 4 times in a period of less than 60 days. And we just saw a bust of a bagel shop that had it so sophisticated that all they had to do was ask for a Special K, a box of Special K cereal. And what I was telling them, how much, what quantity, and what was it, and it just came out. I went in, what the cereal, and it came out. It just seems that there's so much more tablets out there than, that you have this constant flow of people coming in and not doing it. Is there a number or a quantification of the amount of what is legally being put into the pharmacies, legally written for, and then when you're saying 7 million people have come on, underneath that category, this category, does the numbers match up with the overall amount of prescriptions that are out there?
Yeah, they do.
Yeah, it's because of the black market that's associated with a lot of this use, it's almost impossible to tell that. You're looking at people move from state to state, they move from pharmacy to pharmacy. Again, if you are willing, and good, bad, or indifferent, if you're willing to pay cash for prescription, it pretty much doesn't go into any database anywhere. And so, one of the things that I teach my pharmacy students is how to, and my pharmacists, I guess, is to be aware of the fact that if you've got somebody who's coming in and it's a prescription from out of state, it's for a doctor that you don't know, it's for a patient that you don't know, it's for a pretty large quantity. And people who have chronic pain, that's the problem, is if you've ever treated a patient with chronic pain, they can go through 300 oxycodone in a month. So, but again, people are very, very sophisticated. They'll get 6 or 8 prescriptions for 100 or 90 instead of 1 for 500, because that's going to have, all the bells and whistles there. So you get 6 or 8, and then you're willing to pay cash for it. So there are clues that we see in pharmacy that will, kind of be an idea. And a pharmacist can refuse to fill any prescription that they choose to, for, as long as it's, not discriminatory, I guess. But so it's there's so many factors that are involved in the process that the solution is going to have multi-factors too. So I think I've hit on this one again. Oh, yeah, I'm sorry.
Just a quick question. Is there an increase in people abusing Suboxone and Subutex now because of this? Because I've heard of people, I mean, I know that they changed it to
They
dissolvable strips, so it can't be crushed and snorted. But for something like that, I feel like I've known, I'm 20 years old, so this is my era. This is the drug of
That's your
my
drug,
era.
okay.
So this is what I saw in high school. I didn't see pot. I saw Xanax and OxyContin. So if somebody knew you were getting your wisdom teeth pulled, the first thing that they
Oh,
asked you was,
absolutely.
"Oh, did you get extra strength Vicodin by any chance?" That was the first thing that somebody asked you. So now that I'm in college and furthering my education, I see a lot more people going and, their parents are catching them now, because it's very hard when you see somebody nodding out. You obviously know that there's something wrong with them.
Mhm.
Because they've gotten to the point where they're doing 30 OxyContin a day and then snorting a gram of Coke on top of that. So once you get caught, then their parents send them away, they come home, and then they're on Suboxone. Then they're on Suboxone for a while, and then they're fine, and then all of a sudden they're taking their Suboxone and
Along with
snorting Coke with
everything
it,
else, yep.
and still getting high.
All those things are, you actually did a very good job of painting the picture of what that looks like. The statistics are not out there yet, probably because it hasn't hit with the level that we see with things like oxycodone. There are much more strict controls around Suboxone than there are with oxycodone. You have to be registered to prescribe it. You have to be registered to be a pharmacist who can fill it. And so there's a lot more they built because of the fear. They built a lot more controls around that process before you even hit the market.
Actually, despite your second question, I'm here on Staten Island for the past 3 months now, actually, and I was shocked to hear the price of a pill for Suboxone on Staten Island. It is huge, actually. In Westchester, a Suboxone pill can be $8, but I understand on Staten Island it is really astronomical. So to answer your question, yes, Suboxone is being diverted, and
I'm not surprised.
and interestingly enough, about 2006 actually, I was mentioning that I was with the city, and we had Schultz from Ricketts Kaiser, I think, who actually were sort of monitoring diversion. So there's clearly data on diversion as to how much. So it's just a matter of actually finding it. So bottom line, though, that was actually a really excellent question. There's a market for Suboxone, and I just learned that on Staten Island, the incentive is huge. Huge.
And one other question, are you familiar with the research on the naltrexone pellet, the implant?
I am not. I don't
Yeah,
know.
want to say more about it? What's the question?
The naltrexone pellet. I've heard of a doctor, and I've spoken to him. I called him up because I was actually just interested in it. And I've seen him put it in before, and it's a very painful thing. He actually straps the patient's arm.
Correct, actually. Say no more. It's a horrible, it's certainly not an evidence-based practice, and a couple of years it was associated with horrible deaths in New Jersey. It's actually where they make subcutaneous cuts and implant it in the omentum, and it's a rogue, again, that's maybe my word for the day, process, and I'm sure he's charging exorbitant sums of money.
Thousands of dollars.
Yeah, thousands of dollars for a procedure that's just a joke.
And he sends you home with your own staple.
Well, that's the reason why the person
Wow.
died in New Jersey from this procedure, right? So it's a procedure out of desperation and, again, unethical medicine and practice. So it's just outrageous. It's not something that anyone should do.
Wow.
However, though, actually, I don't want to divert too much, but there is Vivitrol, which is intramuscular naltrexone, which is used to treat people with alcohol dependence. And I think Reckitt Kaiser is really trying to get it.
It was approved last year.
It was approved for opioid prevention. Maybe you want to say some more about that, Stephanie?
Well, it would be a great option for patients who are addicted to opiates to have this once a month injection called Vivitrol, which is an opiate blocker. And problem is Medicaid doesn't cover it, and costs about $1,000 a month for the prescription. So right now it doesn't make economic sense, but perhaps in the future when state Medicaid get on the bandwagon with this, it could be a great option for a lot of patients.
But being blunt, run from that doctor really, really fast.
Yes.
It kills people, and again, the follow-up is just worse than I would imagine. Hopefully there aren't any vets in the audience, but I'm sure a good vet would not treat the pets like how you would get treated if you got that pellet in your abdomen.